Hi, this is Janet Braun. Welcome to Competency 8, Diabetes in Pregnancy. As nurses, there are three major concerns that we have. They are how to help the woman with diabetes through pregnancy with good glucose and insulin control, how to protect her infant in utero from the adverse effects of the disease, and how to care for the infant in the first 24-hour period after birth, which we will talk about with the high-risk newborn competency. Since 1921, with the advent of insulin production, women with diabetes have been able to survive to childbearing age and become pregnant and carry a pregnancy. So we now care for many women who have diabetes in pregnancy. Pre-pregnancy counseling for these women is really important to help the woman have optimal control of her blood glucose before and during pregnancy. Our hemoglobin A1C goal is less than 6%, and it's ideal when pregnancy can be diagnosed early. The woman's insulin needs initially in pregnancy will be decreased because of her increased metabolism, but insulin needs will increase by the second half of pregnancy. The woman is at risk for hypoglycemia at night particularly. Other increased risks with the pregnant woman with diabetes include pregnancy-induced hypertension, yeast infections, and a large baby, which can lead to a difficult birth. This slide shows the risk factors for gestational diabetes. Screening for gestational diabetes begins on the first prenatal visit if the woman has any risk factors that exist. If she has no risk factors, all pregnant women are then screened by 24 to 28 weeks of pregnancy. And that screening, or the first prenatal visit screening, consists of the 50-gram glucose test. 50 grams of glucose is ingested. 1 hour later, a venous lab glucose is drawn. That level should be below 140. If it's above 140, the woman is scheduled for the 3-hour glucose tolerance test. And you see the 3-hour glucose tolerance test here. She has a fasting glucose first, then takes in the 100 grams of glucose, and then the lab draws for glucose are at 1, 2, and 3 hours. If any two of these results are abnormal, the diagnosis of gestational diabetes is made. This slide shows outcome risks from diabetes in pregnancy for both the mother and for the fetus or neonate. And you can see on the mother's list I've added cardiovascular disease, which should be evaluated at some point after her pregnancy. Whether diabetes is gestational or type 2 is sometimes difficult to distinguish. A woman may have had diabetes type 2 pre-existing but have been undiagnosed. And so if she has diabetes in pregnancy, gestational diabetes typically is onset after 20 weeks. So whichever the cause, in the postpartum period, the woman needs follow-up. Because any persisting diabetes after that time is then considered diabetes type 2. Nutrition is one of the most important factors to address. Dietary control can be achieved in some pregnancies when it is begun early. So the woman's nutrition is going to be affected by nausea and vomiting if she has those problems in early pregnancy. Dietary intake generally is recommended 1,800 to 2,200 calories per day, individualized for the woman. And that should be divided into 3 meals and 3 snacks that are evenly distributed throughout the day. Of those meals, 20% of the intake should be high-quality protein, 40% complex carbohydrates. So those carbohydrates with low glycemic index. And much of that carbohydrate should be high in fiber, so we need to teach about fiber high fiber foods. 40% of her intake should be high quality fats. So the quality of food is as important as quantity and needs to be addressed in nutrition education. A late evening snack is important that should include protein and complex carbohydrate to prevent nighttime hypoglycemia. And the women should be taking a folic acid supplement, a minimum of 400 micrograms per day, and also a vitamin D supplement. Recent research shows that vitamin D reduces insulin resistance in pregnancy. The woman should have a regular daily plan for exercise during her pregnancy, which should be consistent and not fluctuating to help balance her blood sugar. She should take a snack before exercising of protein and a low glycemic index carbohydrate. And the recommended exercise is 30 minutes of walking per day. Many women will have other varieties of exercise, but if she doesn't already have a plan, this is a good one to start with. Blood glucose monitoring is done by finger stick, and some women will have continuous blood glucose monitoring, especially those with type 1 diabetes. Optimal glucose control in pregnancy is critical because if the glucose is out of balance, the fetus runs high risk for congenital anomalies. So diet and exercise management are first-line therapy in managing diabetes in pregnancy, and that includes frequent blood glucose testing. The woman will have testing during every trimester, hemoglobin A1C, with the target being less than 6%, and ophthalmic evaluation for changes in her retina, and urine culture for the possibility of asymptomatic UTI. During her prenatal care, diet and exercise should be assessed at each visit, and teaching should be reinforced. Placental and fetal monitoring are performed. First trimester screening is typically done for the woman with diabetes to look for markers for neural tube defect or other genetic defects such as trisomy 21 in the fetus. If first trimester screening has not been accomplished, usually second trimester screening including a serum alpha-fetoprotein for neural tube defects. An anomaly ultrasound screen is usually done at 18 to 20 weeks of pregnancy to look closer at the fetus, and in the third trimester, weekly non-stress tests, biophysical profile, and fetal kick counts may be done to assess the well-being of the fetus. At about 36 weeks, an amniocentesis is performed to assess fetal lung maturity, and they're looking at the PG content rather than the LS ratio at this time because the surfactant is formed later in babies of diabetic mothers. Here is a list of nursing diagnoses that are possible for the woman with diabetes in pregnancy. These will be important in planning your nursing care. The educational part of the nurse's role in diabetes of pregnancy is one of the most important parts. Excellent glycemic control is something that the mother needs to understand well, and the consequences of lack of control to herself and her baby. Nutrition education is a very high priority, and so that includes, as we mentioned before, high fiber diet, which results in less postprandial hyperglycemia and decrease in insulin needs. So her meals will be 3 per day plus 3 snacks, not forgetting about that important bedtime snack because of the risk for hypoglycemia at night. So she needs to understand why hypoglycemia at night is a problem for herself and for the baby, and have a good snack of protein and a low glycemic index carbohydrate before bed. So once again, 20% of her food intake protein. Talk about protein sources so she can identify quality sources of food. 40% complex carbohydrates like fresh whole vegetables, and no high glycemic index foods should be included. So we need to do teaching about that. 40% of her intake, high quality fats. We will need to educate the woman about exercise, about her glucose monitoring, maternal and fetal well-being, and the testing that will be done. We'll talk about a plan for delivery and medical management of her diabetes, either through insulin or metformin medication. Metformin therapy in pregnancy is much more common now. It was once thought that metformin was a teratogen to the fetus and contraindicated during pregnancy. But glyburide and metformin are now being used during pregnancy. We do know that metformin crosses the placental barrier, but it's no longer believed to be a teratogen. However, there have been no long-term studies on outcomes for the newborn or child. So those are still needed. Metformin acts by lowering the blood glucose by decreasing hepatic glucose output and increasing insulin sensitivity, as well as enhancing the peripheral glucose uptake in the woman's cells. So you know about the action of metformin, and that has proven to be beneficial in pregnancy as well. Metformin therapy has shown to have better treatment satisfaction among patients than insulin therapy, where the woman would need to give her own insulin injections. And because there's higher satisfaction, there's better compliance and improved quality of life. Still, we need to have long-term outcome studies on metformin in pregnancy. The woman with gestational diabetes may be started on insulin if diet or medication therapy is unsuccessful. Insulin needs, as I said, will decrease in early pregnancy, and then as her pregnancy continues, her insulin needs will be adjusted as her metabolism changes. So the insulin ratio you see there in parentheses, her intermediate acting to short acting regular insulin. Typically the woman will have 2/3 of her daily insulin before breakfast, a 2-to-1 ratio insulin mix, and 1/3 of her insulin before dinner, 1-to-1 ratio. She may have an insulin pump, so she can receive continuous subcutaneous infusion of insulin at about 1 unit per hour. And so then we need to be careful not to get the pump wet, change the site every 1 to 2 days, and do frequent blood glucose testing. Labor and delivery management with diabetes. Vaginal birth is preferred at approximately 37 weeks so that the baby does not get to be too large. So Cervidil IV Pitocin may be used to begin the induction of labor, and an IV insulin drip and IV glucose drip are run simultaneously during labor to manage her blood glucose. There's continuous fetal and uterine monitoring that the nurse will do, and regular glucose monitoring hourly. Very important to maintain meticulous glucose control to prevent rebound hypoglycemia in the newborn. In the postpartum period, no insulin is needed immediately. For the type 1 diabetic, she can then re-regulate her insulin in about 2 to 3 days. For gestational diabetes, sometimes it resolves in the first day and no further treatment is needed. But at least 40% increased risk of developing type 2 diabetes at some later time. So these women need follow-up blood glucose around 6 to 12 weeks and regular annual testing after that. Type 2 diabetes postpartum treatment might include the several oral hypoglycemics that you see here. Breastfeeding is encouraged for diabetic mothers. In the postpartum period, we want to review her nutrition education for diabetes. And remember that there's significant risk for development of diabetes in the future, not only by having gestational diabetes, but also the woman with gestational hypertension or preeclampsia has increased risk. The nurse has a unique opportunity to help prevent diabetes through teaching throughout the lifespan. Thank you.